All right, Dr. Tim Johnson.
Bottom line, what we need to remember is that CT is the leading source of medical radiation exposure in developed countries. We need to take a multifaceted approach to reducing exposure. First of all, the elimination of unnecessary exams that offer little likelihood of clinical benefit is important. But also, if we as techs ensure that the patient receives the lowest possible dose to provide a fully diagnostic study, that would make a great impact also. Now, how can we do that? Well, first of all, we need to understand that in CT there's what's called radiation penumbra. It is the excess radiation that does not contribute to image quality. During helical acquisition, this penumbra will overlap and build up. As you increase the thickness and detector number, this effect decreases. So, if we pay attention to the protocol details, and especially the acquisition parameters that we've been talking about, we can control to a certain extent how much radiation the patient receives. Another thing that we can do is also control the number of phases done. In other words, a lot of times a patient will come in and they will get a scan without contrast, with contrast, and then a delay, especially when it has to concern the abdomen and pelvis. There's been a move recently away from this and doing just with studies without the delays, or a shorter delay to just only include the kidneys. There are other ways to control the radiation dose received. The first one is to set manual techniques based on patient weight and the body part imaged. Now, there are downsides to this. Number one, it results in a lot of different techniques that are used for the same exam, and it's very detailed. There's too much room for error. It can result in suboptimal exams if the wrong protocol is used. A better method is the automatic exposure control. This automatically modulates the X-ray dose given to the patient depending on specific information obtained by the scanner about the patient. There are three types of these. The first is the Z-axis. The Z-axis relies on attenuation measurements derived from the actual patient. It's obtained during the scout image acquisition, and it creates a dose profile tailored to that specific patient. There's also the XY tube current. It refers to exposure control that varies during the gantry's 360-degree rotation. That's during the actual scan, and it changes the tube current due to the patient's shape. Now, the better method is the combination of both, and that is the most effective AEC control. The final variant is the ECG. Now, this is used during cardiac imaging, and the technique is decreased when you're not making an image that needs to be reconstructed. Lastly, we're going to discuss scan length. Now, scan length is self-explanatory, and scan length varies on the body part that you're imaging. With a chest, you're going to have a medium length scan. A head or an extremity is going to be a smaller scan. And when you do your combination scans, you will have a longer scan length. Now, all of this information is well and good, but what does it mean to us when we sit down in front of the control panel to scan our patient? Well, on the computer screen, there is the software where all of these scan acquisition parameters are set. Now, it's not going to say specifically scan mode necessarily. It's not going to say specifically scan length. But let me give you an idea of what it will show. This is the screen that's available with the software that comes with an 8-slice GE scanner. Now, under scan type, you're going to find the area to set your scan mode and your rotation time. Under thick, speed, and interval is where you will set the technique that affects the detectors and slice thickness as well as pitch. You have your scan field of view now. That is self-explanatory. You will set small or large. KV and MA is where you would go into to set a manual technique if you're able to. A lot of the machines these days use AEC, but when you have a pediatric patient, you might want to go in there and set a maximum amount that it will allow. And lastly, you've got start location and end location, which is actually going to give you your scan length. Now, the thing that we need to remember is that there is a fundamental difference in how images are acquired and how they are reviewed in multi-detector CT. Some of the key points to remember from this lecture: helical scanning is preferred for almost all cases and is essential for volumetric imaging. The only exceptions are coronary calcium scoring and brain scans. Protocol design should incorporate the highest resolution setting that will provide the coverage needed in an acceptable time frame. You need to take into consideration patient's breath hold or the contrast media injection duration. Consider the purpose of the exam. Examinations intended for 3D imaging should be performed using the highest resolution and the smallest thickness whenever possible. Field of view chosen should always be as small as possible to accommodate the anatomy of interest. Corresponding slice thickness should also be used to maximize resolution, given limitations in anatomic coverage needed or scan duration. For most general examinations, a helical beam pitch between 1.2 and 1.4 is ideal. For orthopedic imaging and some neuroimaging, pitch values of less than or equal to 1 may be used. Now, how does all this translate? Well, the things that you've read in the chapter and the things that have been presented here can be put in your head to be considered later on. Like we've discussed several points here about hardware. Does your patient have hardware? How can you accommodate for the streak artifact that's going to come from that hardware? Well, there's a couple different things you can do. You can decrease the pitch. The scan time will be longer. You'll have more sampling. You can increase the KVP, which is going to harden the beam. And you can do a longer rotation time. Again, it's going to increase that sampling. The downside is, and the thing that we need to remember, is that there will be an increase in radiation dose. You need to make sure that the benefits outweigh the negatives. You have an obese patient on your table. Well, one of the ways to negate the body habitus artifact is a longer rotation time. You're going to get more technique in there, and you're going to get more sampling. Again, the thing that we need to remember, the bottom line when we choose to set or choose to change any of these techniques, is to always ensure that the patient receives the lowest possible dose of radiation that will provide a fully diagnostic study.